For most of human history, sexual problems were either a moral failing, a medical mystery, or simply something you didn't talk about. That started to change in the 1940s when Alfred Kinsey, a biologist, not a therapist, published research suggesting that human sexuality was far more varied than anyone was officially admitting. His work was controversial, but it did something important. It made sexuality a subject you could study without shame attached to inquiry. That opened the door for Masters and Johnson in the 1950s and 60s, who brought human sexual response into a laboratory setting for the first time. Actual data, a clinical framework, and the beginning of an idea that sexual problems could be addressed therapeutically, not morally or medically, but therapeutically. That's the field we're talking about in today's episode. Welcome back to Licensure Lifeline, the podcast that helps you build the clinical knowledge and confidence you need to pass those pesky exams on your way toward becoming a therapist. I'm your host, Matt Lawson, and today we're covering the topic that comes up in practice far more than it comes up in training, sex therapy. We're going to hit the key figures who built this field, the main clinical approaches, and what it actually means to be a sex-positive therapist when topics like kink, fetishes, and alternative relationships walk through your door. And yes, there are multiple choice questions at the end, so just stick with me. Before we get into this, a couple of quick things. The community that I have been building, the online community for Licensure Lifeline I've been building, is done. I'm going to be launching it in the next couple of days, and I will have a link in the show notes. If you click on it and you don't get anything for a minute, just give me a sec. Like I said, in the next couple of days, this podcast is coming out on Wednesday, May the 13th. So, by Friday of this week, it should be up. Super excited about this. Super excited to see, if this is something that I can continue to build and will help a lot of people. So be looking for that. Also, just a quick reminder, if you have comments, questions, want to talk to me, the best way to do it is through either the Instagram page, or you can email me at licensurelifeline@gmail.com. Licensure Lifeline, all one word. But they have a feature in the podcast that lets people send fan mail, that they call it. I can't respond to those notes. It doesn't let me respond to those notes. It doesn't give me any information on the person that sends the messages. And I feel bad because there's some really good questions that come in a lot of the times, or people commenting on the show, and I want to be able to respond to them other than in the intro. Next up, really great response to the newsletter. I have been doing a weekly newsletter that I will, that follows the podcast. I will be launching that along with this podcast as well, probably this evening. I'm really glad people are liking this and signing up for it. I've been pleasantly surprised to see how many people have really signed up for this as part of their study process. But along with kind of reinforcing the things I cover in the podcast, I do try to expand the knowledge base in the newsletter. And again, there will be a link in the show notes so you can sign up for that as well. Okay, that's going to be it for the announcements. Let's get into the news segment. First up, let's talk about tech and mental health. This one is interesting because it touches on something clinicians are going to be navigating more and more. Google recently updated its Gemini AI app to a more prominently surface crisis hotline connection when it detects someone may be at risk. This has been in the news a lot. Just the sense of, people using chatbots, large language models for therapy. And a lot of the times when they bring up things like suicidal ideation, stuff like that, the AI has not been the best at getting people connected to the services as quickly as possible. So it sounds like Google is really trying to up this. Their clinical director made the case that shutting these tools down isn't the answer, that making them safer and more connected to real support is. And at the same time, a new survey out this week found that more than 1 in 5 Americans have now used AI chatbots for mental health support. Top reason wasn't convenience, it wasn't emotional safety, just lower barrier to entry. And Folks, we're going to see more and more of this. My hope is that the message that gets out there is potentially this is a great place to start, or this is chatbots actually can be used in coordination with an actual therapist. But it is a conversation that we're going to have for the next several years around the role of AI and chatbots in working with individuals. So if you're not familiar with them now, I highly recommend you get familiar. Next up, something relevant to a lot of you around testing and licensure. The Counseling Compact is officially live. As of last month, Louisiana joined Arizona, Minnesota, and Ohio as the first 4 states fully operational in this system. What this means is practically is that licensed counselors in those states can obtain privilege to practice in other compact states almost instantly. So through this shared data system, 35 more states were actively working through the steps to join. So if you're pre-licensed right now, this doesn't necessarily affect you. You need independent licensure to participate, but this is the direction that the field is moving, and it's worth understanding before we get there. This is good news for us. This is going to mean that you're not going to necessarily need multiple licenses to work out of multiple states, and especially with tech the way that it is, and us having the ability to do video therapy, over distance. I mean, this does and I've talked about this before. We have therapy deserts in this country. We have places where there just aren't that many therapists. I live in Colorado, and I love the fact that I can work with people, especially in the wintertime, that often get isolated in the mountains where there just aren't as many therapists. And I can work with them over video as long as they have an internet connection and the snow hasn't taken it down through that. But you have places like, the Dakotas and Vermont and places in the South that just don't have as many therapists. And so this is going to allow just more access to mental health. All right, let's get into the main topic today, sex therapy. We're covering a lot of ground today, so I'm going to move with some purpose, but I want to make sure you walk away with a real clinical foundation here, not just a list of names to memorize. We're going to hit 4 areas: the key figures who built this field, the main clinical approaches, what it means to be a sex-positive therapist, and we'll talk about alternative relationships, kink, fetishes, those things. If there's one thing being a profession in this field has done, it's done many things for me, but it has really opened my eyes to the depth of sexuality, human sexuality, and sex lives. It's absolutely fascinating topic. It is not easy to become a sex therapist. It is not as easy as just saying, oh yeah, this is an area of emphasis. They actually have a serious background that you have to go through, certifications that you have to go through to become a licensed sex therapist. And, if this is a field that's interesting to you, I highly recommend that you look more into it and really get into it and start as soon as you pass these tests, because it does take a minute, but it is so, so needed. I cannot tell you how often I talk about sex and relationships with individuals. It is such a significant part of so many individuals' lives, and they just don't have very many places to really talk about what they go through with sex and their sex lives. So let's get into some of the founders of this field. Alfred Kinsey, I mentioned him in the intro and the historical vignette, gets credit for being the first. This is 1940s, 50s. Kinsey, who was a biologist, not a therapist, published research showing that human sexuality was far more varied than anyone officially acknowledged. His big contribution was the Kinsey scale, the idea that sexual orientation is not binary. It's a continuum, like so many other things in our world. um, getting away from black and white thinking when it comes to intelligence, when it comes to sexuality, when it comes to autism. I mean, it is that we have these scales, and his methodology has been debated over the years, but the cultural impact was undeniable. He made sexuality something that you could study without shame and attached more to inquiry. Then came Masters and Johnson. William Masters, he was a physician. Virginia Johnson, she was a researcher. And together in the 50s and 60s, which must have been just an amazing time to study this topic, they did something pretty audacious. They studied human sexual response in the laboratory setting. So direct observation, physiological data, real science behind sexual response. And out of that work came the human sexual response cycle. Four phases: excitement, plateau, orgasm, and resolution. That model became the foundation of sexual therapy as a clinical discipline. They also gave us a sense of focus, a structured technique we'll talk more about in a minute, and they reframed sexual dysfunction as a couple's issue rather than just an individual one, which is extremely important in a very difficult topic for a lot of couples to talk about. I've worked with a lot of individuals trying to conceive, and that it is like this idea of one person being dysfunctional and having this issue. It can't persist. It needs to be something that's looked at as a couple. Next up in the area of sex therapy, you have Helen Singer Kaplan. She's important because she pushed the field toward in a more meaningful way. Kaplan was a psychiatrist and a psychoanalyst. She recognized something Masters and Johnson's model was kind of missing, and that's desire. Their cycle started at excitement, but Kaplan argued that desire comes first, which absolutely makes sense, right? Like, it's not just, you see somebody and you become excited. There's desire first. Like, do you even want to have sex in the first place? The question matters enormously when you think clinically, especially when clients present with low libido or avoidance. She added desire as a distinct phase and gave us the triphasic model, which I remember seeing on the test. I remember seeing something about the triphasic model: desire, arousal, and orgasm. Her key work was the New Sex Therapy, which was published in 1974. Finally, and this one is highly testable, Jack Annon, A-N-N-O-N, in the PLISSIT model. This is a tiered framework for how any clinician can address sexual concerns, not just sex therapy specialists. The 4 levels are P, permission, simply normalizing the topic. A lot of people experience that you're giving them clinical permission to talk about this topic without shame, which, again, extremely important. Then you have the LI, limited information, basic psychoeducation, sharing relevant clinical information without going too deep. Then the SS, specific suggestions. This is more targeted clinical guidance for specific concerns. And last, IT, intensive therapy, a referral to a specialist, a sex therapy specialist at this point. So here's key clinical takeaways. Most generalist therapists are operating at a permission and limited information level, and that's completely appropriate. You don't need to be a certified sex therapist to create a safe place for these conversations. This PLISSIT model gives you a framework for knowing exactly where you are and when to refer. So getting a bit more into approaches and techniques in sex therapy, let's talk about what sex therapists actually do. So sensate focus is probably the most well-known technique. It comes directly from Masters and Johnson. The idea is to use structured gradual touching exercises that remove performance pressure entirely. You start with non-genital touch, just noticing sensation. And let me preface this. You're not touching the client, right? Like, you're not touching the person that you're working with, but you're talking to them about just noticing touch on their body. So no, there's no agenda here. Over time, the exercise progresses toward more intimate contact. The goal isn't intercourse. The goal is reconnecting with physical pleasure without anxiety, running, or like anxiety just like taken away from the whole experience. It's highly effective for performance anxiety, desire discrepancy between partners, and a range of arousal and orgasmic concerns. Next up, cognitive behavioral approaches are a big piece of this field. A lot of sexual dysfunction is driven more or maintained by disordered beliefs. I should always be ready. Something is wrong with my body. My partner will leave me if I can't perform. I cannot tell you how often this comes up when I work with somebody around sexual performance or struggling in the bedroom. The way that they talk to themselves, the thoughts that they have running through their head about sexuality and their ability to perform. CBT challenges those beliefs directly, combines them with psychoeducation, and uses behavioral exposure to gradually reduce avoidance. It's a strong fit for performance anxiety and arousal disorders. Next, we have psychodynamic approaches. This is Kaplan's influence showing up. Sometimes the root of sexual concern isn't behavioral. It's relational or historical. So attachment patterns get looked at here. Early experiences around sex get looked at here. Unresolved relational wounds are addressed. These can all show up in the bedroom. When a client's sexual concern doesn't respond to behavioral intervention, going deeper into those meanings and history is often where the real work is. Mindfulness. This next up is mindfulness. This is one, again, that I use a ton in my practice. So mindfulness-based approaches. And this has grown out of evidence-based, particularly low desire or arousal concerns. The idea is helping clients reconnect with bodily sensation without judgment. I really use a lot of mindfulness, a lot of DBT work, like in my eating disorder world when I work with individuals, and sex therapeutic type roles as well when I work with individuals. Mindfulness, it goes over so many areas of a person's life, and just being able to reconnect them with their selves, with their bodies, with that moment is extremely helpful. Finally, we have medical collaboration. So sex therapists frequently work alongside physicians, pelvic floor physical therapists, and OBGYNs. Knowing when to refer out and to whom to refer to is a clinical skill. Vaginism, periunia, erectile dysfunction, these all have potential medical components. And a good sex therapist isn't working in isolation. That goes for therapists in general. Getting friends that are doctors, physical therapists, nutritionists, dietitians, when you are starting off in your professional life, is just going to make the people that you work with, their experience that much better with you. If you can readily refer out and you have those contacts ready to go, it is going to just make all these processes that we're talking about here so much easier. So that's kind of a nice overview of sex therapist. What their lives are like. For the exam, the common presenting issues you want to know are things like erectile dysfunction, premature ejaculation, hypoactive sexual desire disorder, vaginism, dyspareunia, orgasmic disorder. Know what they are and have a sense of which approaches fit in which presentations. All right. This last part, I'm going to talk a little bit about what it means to be a sex positive therapist. And again, like this is more for my general therapist, I think, that I'm speaking to here, people that are just kind of considering just becoming a generalist for the most part with therapy. I'm pretty much a generalist. I consider myself, even though I have specializations in a lot of different areas. But sex positivity is kind of a stance that you're taking with individuals just around this kind of this non-judgmental way of looking at a person's sex life, but also a really well-informed way of looking at a person's sex life. So this is where I really want to slow down, because this section isn't really about technique. It's more about how you are in the room. Sex positivity as a clinical stance does not mean you're personally endorsing every sexual behavior or lifestyle. What it means is that you approach sexuality without shame, without pathologizing, without subtle or not so subtle imposition of your own values in the client's life, right? So this is Rogerian, come as you are, positive regard for the individual sitting across from you, non-judgmental ways of looking at what they're bringing you, with being well informed. Your job is to create a space where the clients can explore their sexual concerns, identity, and experiences without fear of being judged, redirected, or quietly evaluated. That's a higher bar than it sounds, because most of us have absorbed a lifetime of cultural and personal messages about what sex is supposed to look like. This really came to a head in my practice when I got my first polyamorous client. And, I had been raised in a monogamous household, that where two people get married and that's it. I didn't know much about polyamory. And if you don't know what polyamory is, it basically means more than one love. This idea that you can have more than one partner, more than one love in your life. And, if it's done right, it works out extremely well for certain people. So the starting point is self-awareness with all of these things. Your biases and discomfort will show up. The question is whether you've examined them before they show up in the session. That's exactly what supervision and personal therapy are for, is examining these aspects of our lives. Language also matters more than people realize. If a client uses casual, specific, or explicit language to describe their experience and you respond by shifting into clinical sterility, they notice. You don't have to mirror everything, but you do need to not flinch when they talk about things that are seemingly taboo. The way you receive what a client tells you about their sexuality, communication, speaks volumes about whether it's actually safe for them to keep talking. When you feel uncomfortable, because you will sometimes, learn to distinguish between 3 different experiences. So first would be, I need more training on this topic. That's a competency issue. Go get the training. Next, this conflicts with my personal values. That's a values issue. Get the supervision to figure out whether you can work with these clients ethically. And lastly, or this client needs a level of specialization I can't provide. So recognizing at yourself, and that's when you're going to refer out, right? The resources here to know, AASECT, the American Association of Sexuality Educators, Counselors, and Therapists. Again, that's AASECT. I'll have a link in the show notes for that one. But if you want further training, consultation, or need to find a specialist, that's going to be a really great resource for you. I also want to talk a little bit about things like kink and fetishes. In this section, it's most training programs, they skip entirely. We didn't talk too much about these types of things when I was in school. I ended up having to learn a lot on my own. Had some really cool sex therapists that I knew in my life that I was able to learn from, and then supervision really helped with this. So this means your clients are often more informed, especially initially, about this topic than you are. And, the idea here is to really change that, to get as many therapists as up to date as possible. So first up, ethical non-monogamy, ENM. This is an umbrella term for relationship structures involving more than 2 people. So I talked about polyamory. And these individuals have full knowledge and consent of everyone involved. Under that umbrella, you have open relationships, you have swingers, you have relationship anarchy, and there's other terms that just, they're kind of considered fringe communities. Research suggests somewhere between 4 and 5% of Americans are actively participating in some form of ethical non-monogamy. These communities are pretty amazing, and it takes a certain person type to be able to do ethical non-monogamy well. And we're not talking about individuals that are in a relationship and they're cheating for the most part on their partners. These are individuals that are in relationships with people and they all knowingly have multiple partners. The communication level in these communities, when they do it right, is off the charts good. Some of the best communication in relationships you will ever see are in these communities, because you have to communicate well. But the clinical stance here is pretty straightforward. Don't pathologize the structure. Your job is not to evaluate whether non-monogamy is healthy or risky as a lifestyle choice. Your job is to assess the same things you'd assess in any relationship. It's consent going well, communication set pretty well, emotional well-being is in the right place, and whether the person in front of you is getting their needs met. What often comes up in ethical non-monogamy is jealousy. That's one of the biggest ones, and that's why I kind of prefaced this idea that this is not for everyone. If you struggle with jealousy, if you're a jealous person, that is, and you are interested in a relationship like this, it's something you really have to come to terms with. Jealousy does not work in ethical non-monogamy. It just does not work. And these communities often reframe it as a signal to explore rather than a reason to shut down. Negotiation often breaks down conflicts around hierarchy. Primary versus secondary partners becomes an issue. But there's a lot of time management here. There's a lot of understanding here. There's a lot of a sense that, there's no ownership in the relationship. Like, this is my person. Like, this person across from me is mine. It is more of an openness. Now let's look a little bit at kink and BDSM. BDSM stands for bondage and discipline, dominance and submission, sadism and masochism. And I want to be really direct here because this is both clinically important and highly testable. The DSM-5 draws a clear, meaningful distinction between paraphilia and a paraphilic disorder. A paraphilia is an atypical sexual interest. That's it, right? It's not diagnosed or anything like that. A paraphilic disorder is diagnosed only when that interest causes a person clinical significant distress. Like all things in our lives. All things in a therapist's life, when they're working with somebody, we have to be able to see if this is causing significant distress and whether it involves harm or non-consent. The kink community itself operates around frameworks designed to prioritize safety and consent. Again, highly communicative. When this is done well, it is highly communicative environments. They're safe, they're sane, they're consensual. RACK, R-A-C-K, risk-aware consensual kink. These aren't just slogans. They represent genuine culture of negotiation, consent, aftercare, that frankly a lot of vanilla relationships could learn from. I mean, I'm not kidding here. Like, some of the best relationships I've ever seen are in kink communities and polyamory communities, because there's just so much communication and so much just awareness of the relationships. So what are the clinical red flags here? Non-consent or coercion. Unfortunately, I have seen a lot of people that are in relationships, even married, where one day one of the partners wakes up and says, I want to open our relationship. And, that's a tough one, especially if the other person didn't really sign up for an open relationship. I've seen a lot of trust broken this way. And you have to support people that are kind of struggling with some of these things and power dynamics and things like that. Let's talk about fetishes. They follow the same logic. A fetish involves sexual arousal connected to a specific object, body part, or situation. Again, clinical significance determined by distress or impairment, not by content. The question is never, what does this person find arousing? The question is this causing harm or suffering? Such an important thing to keep in mind. A few things to take away from this section. First, don't conflate kink or ethical non-monogamy with trauma or attachment disorders. A lot of people do that. They immediately hear about these pieces of a person's life, and they automatically assume that they must have experienced some significant trauma because they are in this place. You can explore those connections with the client, but assuming the connection is a clinical bias, not a clinical observation. Second, if these areas are new to you, seek consultation before you find yourself overthinking what all this is. It's super interesting area. I cannot stress enough how needed individuals are that are sex positive, that are sexuality informed. Highly, highly, highly recommend, if you have any interest in this topic whatsoever, that you just get into it and really start to see what it takes to inform yourself. All right, let's get into some multiple choice question. Question number 1. Helen Singer Kaplan's most significant contribution to sex therapy was A, developing the 4-phase human sexual response cycle, B, creating the PLISSIT model for tiered intervention, C, adding the desire phase to create the triphasic model, or D, introducing sensate focus as a clinical technique. Answer is going to be C. Kaplan's landmark contribution was recognizing that desire, the want, comes before arousal. Master and Johnson original model started with excitement, but Kaplan asked a deeper question: what about the person who never gets there in the first place? Her triphasic model, desire, arousal, orgasm, gave a clinical framework to understand low libido and sexual avoidance at a psychological level. Question number 2. A therapist is working with a client who mentions feeling embarrassed about sexual concerns. The therapist responds, "That's something a lot of people experience. You're not alone in that." Which level of PLISSIT model does this represent? Is it A, limited information, B, specific suggestions, C, intensive therapy, or D, permission? Answer is going to be D, permission. The therapist isn't providing any clinical content here, no psychoeducation, no techniques, no referrals. They're simply normalizing the experience and signaling that it's a safe place to talk. Question number 3. According to the DSM-5, which of the following best distinguishes a paraphilic disorder from a paraphilia? A, the specific type of sexual interest involved. B, whether the behavior occurs in private. C, the presence of clinically significant distress or harm to others, or D, the frequency and duration of sexual interest. Answer is going to be C. This is one of the most testable distinctions in this entire content. Just to give you a flag here, a lot of people get tripped up because they assume unusual equals disorder, right? The DSM-5 is explicit. A paraphilia is simply an atypical sexual interest. It becomes paraphilic disorder only when it causes the person marked distress, functional impairment, or involves harm or non-consent to others. Question number 4. A sex therapist instructs a couple to engage in non-genital touch with no expectation of sexual intercourse. This therapist explicitly asks them to focus only on physical sensation. This intervention is best described as A, systemic desensitization, B, cognitive restructuring, C, sensate focus, or D, behavioral activation. Answer is going to be C, Sensate focus. Sensate focus is the signature technique of Masters and Johnson. Structured, graduated touching designed to remove performance pressure and rebuild physical connection. The key feature in this questions are non-genital touch, no expectation of intercourse, and attention to sensation. Question number 5. A pre-licensed therapist has a new client who discloses they are polyamorous in a polyamorous relationship. The client is not presenting any concerns about the relationship. The most clinically appropriate response to this would be A, explore whether early attachment wounds may be driving the relationship choice. B, provide psychoeducation about the emotional risk of non-monogamy. C, proceed with treatment as planned, acknowledging the relationship structure without pathologizing it. Or D, refer the client to a therapist who specializes in alternative relationships. Answer is going to be C. This question is testing your clinical bias as much as your knowledge, right? The client has not presented any concerns about the relationship structure. Exploring attachment wounds assumes pathology. So providing some psychoeducation about risk imposes a therapist framework on lifestyle, and clients didn't ask for that discussion. Referring immediately is premature and potentially stigmatizing. All right, folks, that was a bit of a longer episode today, but this topic is fascinating to me. I love sex therapy, the world of sexuality. It's a great one. Again, please look into it. But we covered a lot of ground, and we looked at, Kinsey's, Masters, Johnson, Kaplan, Anon. You have a working understanding of the main clinical approaches from the sensate focus to CBT and mindfulness work. You know what it actually means to be a sex positive clinician, and why that starts with examining yourself before it shows up in the room. And you have a framework for approaching alternative relationships, kink fetishes, without pathologizing, and what that means. That's not a small thing. A lot of clinicians go years without feeling confident in these areas, and I'm hoping this puts you a little bit ahead of the curve. Before I let you go, I want to make sure that you know about something about again, reiterating the Licensure Lifeline Circle group that is launching here in the next couple of days. I will have the link in these show notes. Sign up for the newsletter when you get a chance. That is just building and growing. I love seeing it. And until next time, keep learning.